Okay, welcome. You've joined us for a deep dive, and today we're looking into something you've clearly been thinking about, how decisions actually get made in healthcare.
Yeah, we've got some really interesting articles you shared, and a central theme seems to be why making what feels like the best choice, this thing called shared decision making, why it often feels, well, complicated.
Right. It's not always as simple as it sounds on paper, is it?
Exactly. You'd think maybe it's just about getting the right medical facts and having a good chat with your doctor. But
Uh-huh.
these sources, especially one from academic medicine, suggest there's like a lot more going on beneath the surface.
Okay, so that's what we're digging into. A framework called Cultural Historical Activity Theory. CHAT, for short.
Chat. Sounds a bit academic, maybe.
It does sound a bit heavy, Cultural Historical Activity Theory, but really it's just a way to look at all the surrounding stuff, not just the two people talking.
Right. The cultural bit reminds us about norms, historical, about past
An
experiences.
activity is just focusing on what everyone's actually doing. Yeah.
Yeah, precisely. And the articles you sent, they're pretty academic, focusing on using chat to understand and maybe improve healthcare education and practice.
So our mission today is to sort of pull out the useful bits, the practical ideas from this theory to help you, listening, get a better handle on the dynamics when healthcare choices are on the table.
Let's kick things off with shared decision making itself. The ideal, right?
Yeah, the partnership,
Hmm.
where your values, your preferences, they matter just as much as the medical evidence. The article even calls it the pinnacle of patient-centered care.
Which sounds great. But what's really interesting is the article immediately points out this gap.
A gap between the ideal and reality.
Exactly. Everyone agrees it's the goal, but the evidence, it suggests it doesn't happen all that consistently. And maybe even more surprisingly, it doesn't always clearly lead to, say, better outcomes, like patients sticking to treatments.
Huh. Okay. So to illustrate why this gap might exist, the article gives us two scenarios, right? Two very different patient-doctor encounters.
Yeah, really contrasting. Let's start with the first one. It's a 21-year-old patient, first time looking for birth control, seeing a resident physician.
Okay.
And this first encounter, it feels pretty traditional. The article calls it paternalistic. The resident's running a bit late.
Mm-hmm. Feeling the time pressure?
Yeah, and sort of rushes through the options, mainly just showing a chart about effectiveness.
And the patient says she's not sure what's best for her.
Right. But then the resident kind of jumps in, says, well, you know about the pill because your sister uses it. Let's just start you on that.
Oh. So not much digging into her life, her actual preferences.
Very little. No real questions about her understanding, her lifestyle. It's a quick recommendation based on, well, limited information.
And the outcome.
Well, she gets the contraception. That was the goal, technically. But she leaves feeling uncertain. It really shows the physician driving the decision, you know? The patient's input isn't really shaping it.
Okay, so that's picture number one. Now contrast that with the second encounter. Same patient comes back a few months later.
Yeah, she's finding the pill tricky, works the night shift, keeps forgetting it. But something's changed.
What's that?
A friend suggested she use a decision aid, like a tool to help figure out birth control options.
Ah, okay. And does the doctor's approach change too?
Dramatically. Turns out the resident had been to a workshop on shared decision making in the meantime.
Oh, interesting timing.
Right, so this time, the resident asks way more questions about her periods, her goals for contraception.
So actually using that decision aid she brought in.
Yes, actively encouraging her to talk about what she values, using the aid as a springboard for the conversation.
So it becomes more collaborative.
Totally. They talk about her heavy cycles, wanting to avoid pregnancy, the night shift problem. They discuss risks, benefits, and together they land on the idea of an IUD.
And the resident explains the procedure.
Yep, talks her through it, and then with supervision places the IUD, a completely different feel.
Wow. So same patient, same basic need contraception, but two totally different processes and likely feelings about the outcome.
Exactly. In the second one, the patient's ability to act on her intentions, to influence things, her agency is much more central.
And this is where chat comes in, helping us understand why they were so different.
Precisely. Chat gives us that lens to look beyond just the individuals. It zooms out to the whole activity system involved.
Okay, the activity system, let's break that down. Chat sees it as having, what, 6 key parts?
That's right. It helps map out all the elements at play. The article lays them out nicely.
Okay, first up is the subject. That sounds straightforward.
It is. It's just the individual involved, the patient, the physician, a nurse, anyone taking part. You, the listener, could be the subject in your own healthcare interactions.
Got it. Then the object.
The object is the point of the activity, the goal. So in our birth control example, the initial object seems to be choose contraception, but as we thought, that can change or get more complex.
Okay. Next are tools or artifacts.
Right. These are things used to achieve the object. It can be physical things, charts, medical knowledge, that decision aid.
Ah, the decision aid was a key tool in the second encounter.
Definitely. But tools can also be less tangible, like language itself, how questions are asked, how info is shared. Realizing that the way a doctor explains things is also a tool, shaping your understanding is, I think, really useful for listeners.
Yeah, that makes sense. Okay, what about rules?
Rules are the guidelines, the norms. Some are formal, like clinical guidelines or hospital policies.
But also informal stuff.
Yeah, like appointment time limits, that feeling of being rushed we talked about, or
Yeah.
unspoken cultural things about, how doctors and patients should interact. If you've ever felt you couldn't ask a question, that might be an unspoken rule at play.
Fifth is the community.
This is basically everyone else involved or with an interest, other medical staff, specialists, maybe the patient's family or friends.
Like the friend who suggested the decision aid.
Exactly. She was part of the patient's community, influencing the activity.
And finally, division of labor.
This just looks at who does what, how tasks are split up, the roles of an attending versus a resident, or even the roles the patient and doctor take on in making the decision itself.
Okay, so those are the components. The article uses a diagram, figure 2, to show these systems interacting in the two encounters. Let's look at that first paternalistic one again through this chat lens.
So figure 2A shows the physician and patient having kind of separate, though interacting systems. They share that initial goal, object 1, select contraception.
Yeah.
But the article points out there's no real shared goal, no collectively meaningful object, object 2, or truly shared object, object 3. They aren't really working together on the process.
It's like they're aiming for the same spot, but taking totally different paths without talking about it.
Kind of. And you see potential tensions. The doctor's using the tool of medical knowledge, but constrained by the rule of limited time. The patient has the tool of her sister's experience, but maybe feels a rule not to question the doctor too much. There's friction there.
Right. Okay, now how does figure 2B, for the second encounter, look different using chat?
Big difference. The physician's object actually changes. It expands. It's not just choose contraception quickly. It becomes elicit patient values and facilitate patient agency. That's a new object 2 for the physician.
And they're using new tools, like the decision aid, and new rules based on that workshop.
Exactly. And the patient's system changes too. Her object broadens to articulate my preferences effectively. The decision aid is her tool, and her friend is part of her community, influencing her actions.
So now they do have shared goals.
Yes. The article highlights this emerging joint object 3. The shared decision-making process itself becomes a common goal. The whole system looks more complex, richer.
More variables, more interaction between the parts.
Right. The decision aid, the friend, the changed approach, they all feed into resolving those earlier tensions and having a proper collaborative discussion.
You mentioned agency again. The article links it to Giddens' definition.
Yeah, Giddens talks about agency as intentional action, the capacity to act on intentions, and the power to make a difference, essentially.
So in encounter 1, her agency was low.
Very limited. She didn't really have the power to shape the outcome based on her intentions. But in encounter 2, the doctor's questions, the decision aid, these things, facilitated her agency. They empowered her.
And chat helps us see how the system either supports or suppresses that agency.
Exactly. It shows it's not just about the person, but the environment, the tools, the rules, the interactions.
This connects to another chat idea mentioned, expansive learning. What's that about?
Expansive learning is this idea that when you work through the tensions and contradictions within or between these activity systems, it can lead to fundamentally new ways of thinking and acting for everyone involved.
So it's not just solving the immediate problem, but learning that changes future actions.
Pretty much. In encounter 2, the learning is expansive. The physician learns the value of this shared approach, likely changing how he interacts with future patients. The patient learns her voice matters, making her potentially more active in future healthcare. It ripples outwards.
Whereas in encounter 1,
Yeah.
not so much learning happening.
Not really expansive learning, no. Maybe the doctor learned how to prescribe the pill quickly, but there wasn't that mutual development of understanding or practice.
Okay, so how can people use this chat framework, say researchers or educators in healthcare?
Well, for researchers, the article suggests chat is a great analytical tool. It helps them systematically map out an activity system, like a clinical encounter, and pinpoint exactly where the tensions, breakdowns are happening that might hinder shared decision making.
So instead of just saying communication needs improvement, they can identify which tool isn't working or which rule is causing conflict.
Precisely. And that feeds into education. For educators, training doctors, nurses, etc., chat can help design more targeted interventions.
How so?
Instead of just saying, do shared decision making,
Yeah.
you can use chat insights to train specific skills, like how to effectively use a decision aid tool, how to elicit patient values, language is a tool, how to navigate time constraints, rules, while still involving the patient. It underlines that it's systemic, not just interpersonal skill.
And the article hinted chat is useful beyond just the patient-doctor dyad.
Yeah, briefly. Things like understanding teamwork better, how different professionals, doctors, nurses, therapists with their different training and goals, different activity systems, might clash or collaborate.
Or communication across specialties.
Right, or even understanding cultural differences in learning or the complexities of care for conditions like autism spectrum disorder, where you have many people and systems involved. Chat provides a way to map all that complexity.
But it's not a perfect model, right? The article mentioned limitations.
Sure, no theory is perfect.
Yeah.
One point is generalizability. Because chat analysis is so detailed and context-specific, findings from one study, say in one clinic, might not perfectly apply everywhere else.
Makes sense. The specific rules or community might be different elsewhere.
Exactly. Another point is about scope. While chat can handle complexity, researchers sometimes need to deliberately focus just on the core patient-physician interaction, for instance, to avoid getting lost in too many external factors.
Keeping the main thing the main thing.
Kind of. And finally, it suggests chat might be more of an analytical tool for educators and researchers themselves rather than something trainees would directly use day to day. It helps the educators understand the system so they can design better teaching.
Okay. So as we wrap up this deep dive, what's the big takeaway from using chat to look at healthcare decisions?
I think the core insight really is that shared decision-making isn't just a nice chat. It's this complex dance. It involves the people, their goals, the tools they use or don't use, the rules, spoken and unspoken, the influence of others, how tasks are divided. Chat just gives us a way to see all those moving parts.
And understanding those parts helps us see why sometimes it works well, like in that second encounter, and why sometimes it doesn't.
Exactly. It's about navigating all these layers to get to a place where the medical evidence and what matters to you truly come together.
So for you listening, maybe think back on your own healthcare experiences. Can you spot some of those chat elements? What tools were used? A website, a pamphlet, the doctor's explanation? What about the rules? Did you feel rushed? Were there unspoken expectations?
Yeah, or the community did advice from family or friends shape how you approached a decision. Seeing your own experiences through this lens can be quite revealing, I think.
And that leads to a final thought, maybe something for you to chew on. Knowing all this complexity that chat reveals, how can we as patients, as providers, as a whole system, actually foster environments where that true shared decision-making, like we saw in the second example, is more likely to happen?
How do we consistently empower people to have that active, informed role in their own care? That's the big question, isn't it? Definitely something worth thinking more about.